So let's move on to the next speaker, which is Carette. Okay. The title of the work is Usefulness of a nociception monitor or nociception monitors to titrate remifentanil with a stable low noxious stimulation response index. Rick is, well, one of the users of NSRI in his clinical practice. So personally, I found this very interesting work, and I look forward to your presentation.
Thank you. Should I talk like this or you hear me? Okay. So, ladies and gentlemen, good afternoon. This is a brief presentation of the results from a study we did in our hospital in OLV Hospital Aalst in Belgium. It's a mid-sized, non-academic hospital in the center of Belgium. As you all know, anesthesia has 3 children: hypnosis, immobility, and ANS control, also known as anti-nociception. The first 2 are excellent students. The third one thinks about a career on TikTok. So it's still looking for its identity. Maybe therefore, on a regular basis, new nociception, so-called nociception monitors are developed. In our study, we tested 3 devices. The first one is the nociception level index, or NO, from MetaSense. The second one is the QNOX from Quantium Medical. And the third one is the surgical PLET index, or SPI, from GE. In between different COVID waves, we managed to get informed consent from 24 patients scheduled for robotic-assisted radical prostatectomy. We used the Zeus anesthesia workstation from Draeger with the Smart Pilot View software installed. And we planned for each patient during the dissection phase 3 20-minute measurement intervals. In these intervals, we gave a specific combination of remifentanil and desflurane. Each patient received a remifentanil effect site concentration of 1, 3, and 5 nanograms per milliliter in a variable order. We adjusted the entitled desflurane concentration to keep a stable NSRI noxious stimulus response index of 5. On the Smart Pilot View window, we had all the data together: effect site concentration of remifentanil, effect site concentration of desflurane, and the NSRI. What we did in this study was actually surfing up and down the NSRI 5 isobol, and we wondered whether nociception monitors could help us find the so-called sweet spot. In other words, could they give us information about either what remifentanil effect site concentration gives us the highest level of nociception, or which is the lowest remifentanil effect site concentration that gives us an adequate level of nociception. We present our data with the mean in black and the median in red. All in all, we had with the 3 different nociception monitors, according to the manufacturer's instructions, adequate levels of nociception in all 3 legs. There was a small problem with some unexplainably high QNOX values, but according to the communication we had with the manufacturer, that was because our monitor was running on an older software version. So this should not be a problem anymore. However, our monitors were not able to give us an idea about the changing remifentanil concentrations. In our study, they did not better in predicting the remifentanil concentrations than tossing a coin. This is clearly in contradiction with other studies that say that these monitors can be used to titrate opioids. So maybe an NSRI of 5 is too low. Maybe at an NSRI of 5, there's no chance for nociception to show. On the other hand, with the stable NSRI, at least from a visual inspection, we have very stable levels of nociception. So could it be that nociception monitors reflect the NSRI rather than the opioid effect site concentration? That should be investigated in further studies at higher NSRI levels. Thank you.
So before we go to the question in the room, can you just elaborate on what the meaning of NSRI is? What does it represent?
Well, the NSRI is a calculated number. It's based on the whole theory of dose response surface, the dose response surface graph that I showed you here with the, okay, was it? Okay. Can I move? Yeah, this one. So over here we have the dose response surface graph. This is a graphical presentation with isoballs. So each point on the isoball, but why am I explaining this to these people? Does anyone know, doesn't know what NSRI means?
No, the problem is I wanted to come to the point that it's NSRI is a measure of a probability of movement response.
Yeah.
So do you expect different analgetic or like nociception monitor values when you titrate to an equipotent probability of inhibiting a movement response? That would be my question.
Maybe not. And my conclusion, or what we suppose of, or what could be a finding, we didn't have that conclusion at the beginning of the study. So we took the NSRI and we targeted the stable NSRI because that is the way we work. So we don't want to change opioid concentration and keeping the concentration of the hypnotic at a constant effect site concentration, because then you increase or decrease your potency.